Good afternoon. Good afternoon to all of you. We are going to get started on this wonderful, wonderful presentation. You all do not even understand what a great experience you're going to have. I've heard Dr. Guilamo-Ramos speak in the past, and he gives a memorable talk when I've heard him in the past, and you all going to learn something new, because he's always trying to make sure that we sort of take it to the next level. So I'm going to do a full introduction of his, looking at his bio sketch. I'm going to give you the full introduction just so that you understand some of the wonderful things that he's done in our profession and for healthcare. So Dr. Vincent Guilamo-Ramos is the Dean and Bessie Baker Distinguished Professor of the Duke University School of Nursing. He's also the Vice Chancellor for Nursing Affairs at Duke University and the Director of the Center for Latino Adolescent and Family Health. He is a nurse practitioner who's duly licensed in primary care and psych mental health nursing. His research examines the role of families in promoting adolescent and young adult health, with a focus on mitigating the mechanisms through which the social determinants of health shape health inequities. Dr. Guilamo-Ramos's research has been federally funded for over 2 decades by the National Institutes of Health and various other extramural agencies. He has published over 100 manuscripts in leading peer-reviewed scientific and health journals, including The Lancet Infectious Diseases, JAMA Pediatrics, and the American Journal of Public Health. He has developed a set of conceptual and applied web resources for social determinants of health that mitigates some of the challenges that we see when individuals are exposed to multiple determinants of health. And we will put in the chat later a website to his work at Duke University and the work he's contributed to nursing. Dr. Guilamo-Ramos's work has been featured by national media outlets, including CNN, NPR, the New York Times, Newsweek, and The Guardian. He serves as a member of the Presidential Advisory Council on HIV/AIDS, the Health and Human Services Panel on Antiretroviral Guidelines for Adults and Adolescents, the CDC and HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment, and he's also on the boards of the Power to Decide, Latino Commission on AIDS, and HIV Medicine Association. He currently serves on the National Academies of Sciences, Engineering, and Medicine, the work that's looking at unequal treatment revisited, the current state of racial and ethnic disparities in healthcare. Previously, he served on the Committee on Prevention and Control of Sexually Transmitted Infections in the United States. He is a fellow of both the American Academy of Nursing and the American Academy of Social Work and Social Welfare. He's also an Aspen Health Innovators Fellow and a Presidential Leadership Scholar. And without further ado, I will turn this over to Dr. Guilamo-Ramos for his presentation, and welcome to you. And we have an amazingly large audience who is just waiting to hear all your wonderful pearls of wisdom. Thank you.
Thank you very much, Dr. Yearwood. I want to start by saying that it's really a delight. I'm excited to be with the Georgetown University School of Nursing, an amazing school. I wish I was there in person, and look forward to having the opportunity to visit the school in the future. Special recognition for Dean Waite. Thank you for the invitation, and also to Dr. Hilton. I'm hopeful that he is participating as well today, but if not, thank you for your leadership at Georgetown University. I'm really excited. I'm going to talk to you about something that I've been thinking about quite a bit. Myself and then also members of my research team, we collectively have worked on some of the ideas that I'm going to put forward. And I hope that what I share today will be something new, and that it will be innovative, and that it will not be simply a reiteration of what we have known for a long time. So with that, I'm going to jump right in. My talk is entitled Emerging Issues Surrounding Social and Structural Determinants of Health and Implications for Nursing Science, but I'm going to broaden that and say for nursing, the nursing profession, for all of us collectively. And so I want to start with really identifying some pretty straightforward definitions, but I am using these definitions in a very particular way. So for me, I tend not to use the term negative health outcome or health disparity. I actually prefer to use the term health inequities. And as we go forward in the presentation, you'll have a better understanding of why it is that I rely on the term health inequities. But just to sort of start with a common definition, health inequities, in my view, are systematic differences that limit the opportunity for all people to achieve their optimal health. And there are three dimensions to health inequities. And so whenever I reference a health inequity, I'm really talking about three things. One, the health status of an individual, of a family, of a community, of broader society. And two important indicators, they're just exemplars, but they're quite important, is morbidity and mortality. And I'm going to be talking about morbidity and mortality in just a couple of slides. The second is really distribution of health resources. And in particular, I'm thinking about how do we go about aligning or allotting, better word, our health resources in our society? Who has access? Who is able to benefit from whatever it is, whether it be health services and institutions broadly, or something more specific like a vaccine or a particular treatment. And then the third dimension of health inequities really speaks to the social conditions in which we all live. And so what are our circumstances in which we're born, in which we grow, we live, we work, and we age? Those three things, health status, distribution of health resources, and also social conditions, are the three elements of health inequities that I'll be talking about today. And so I want to start by giving a couple of examples that have been things that, to be honest, I think we've all been thinking about in the nursing profession and health more broadly. And they've been weighing heavily on our hearts here at Duke, and they've impacted us in terms of how we think about our school and the purpose for our profession. The first is a really striking fact that often gets glossed over. You know, right now, more than half of Americans in our country, adult Americans, already have a chronic disease, and the proportion of adult Americans that are living with one or more chronic diseases is increasing. And so if you look at the slide on the left or the graph on the left, you can see that in that figure, you can see where we are now, roughly the 2025 figure. And then look at 2030, you can see that number is increasing. And if I had presented data on 2040, 2050, what you would see is the increasing burden of chronic disease among adult populations in the US. But even today, right now, more than half of all adult Americans already have a chronic condition. If you think about it on the right, the mortality data, what's really striking is that for more than 4 decades, we've had benefits of a developed country. The US has had tremendous increases in life expectancy. What has been of late troublesome is that we've seen stagnation, and also in the most recent years, we've seen a pretty historic decline where life expectancy in our country has been going in the wrong direction. So when I put these two things together, chronic disease and the pervasive numbers of individuals that are living with chronic conditions and what that looks like for the future, as well as reductions in life expectancy, it's, in my view, a very opportune moment for us to pause as a profession and think about how are we going to address this. This is a really visually, I think, pretty impactful slide. You can see here on the left that there was a great story in the New York Times that really documents the historic falls in life expectancy. You can see that in 2019, life expectancy on average was 79 years of life. In 2021, it was 76 years of life, and that's life expectancy overall. What's even more striking, and which I think many of us who are privileged to work in academia and are nurse scientists, if you look at the map of the US, this image comes from a recent paper in JAMA, you can see that there's a gradient that goes from roughly 57 years of life, which is sort of that darker red, sort of orange color, up to about 98 years of life in the darker blue color. And so there is, across the entire United States, a lot of variability. And if I were to zoom in on some of these areas, including the areas that are the darkest blue that have the highest life expectancy, we would see populations or very specific geographies where the color would be much lower than the dark blue, would be in the orange. And so across our entire country, there are places where we see these differentials in terms of how long people live. And that's something that we should pay attention to. I'm going to be coming back to that. In terms of distribution of resources, a couple of, again, examples. 1 in 10 Americans are uninsured, roughly 32 million individuals. 1 in 5 Americans are underinsured. And so they have health insurance, but their health insurance does not adequately address all of their health needs. So there may be things that they would benefit from being able to access, but they cannot because they don't have a way for paying for that. And then also a pretty startling fact is that 2 in 5 American children right now in our country are covered by a public option. Very appreciative that children are able to access healthcare coverage through a mechanism such as Medicaid, but it also is a statement about kind of who and what we are as a country when we think about 2 in 5 American children are relying on a public option in order to really access what I would consider a basic right, which is accessing healthcare. On the right-hand side, you can see that what is really startling is that uninsured Americans do sort of forego care or they delay care. And you can see in both instances that if you were uninsured, you were much more likely to delay care. And if you are uninsured, you're much more likely to simply go without, to forego care. These are things that I consider exemplars of those 3 dimensions of the health inequity. Our status, our health status in terms of morbidity, mortality, our distribution of resources. And now I'm going to talk a little bit about social conditions. This is one of my favorite slides. I actually like it very much because it shows the complexity of the current challenge that we all face as nurses and as educators in academic schools of nursing. We are training the future workforce to respond to what we see right here. I know in my own nurse training that there was some mention of context, but I don't think that there was enough emphasis on social determinants of health. And the reason why I say that is that what's been really interesting to me is that, 80, in some cases, up to 90% of the variability in whether or not there's a negative outcome is attributable to things that are outside of what would be the domain of clinical healthcare services. And yet, much of my training, I'm not certain what folks on this call would say, but most of my training actually focused on the smaller segment, on the clinical components. And that's not to say that isn't important. As nurses, as healthcare professionals, we should be very proud of our technical skills and our ability to respond clinically to the health of our patients. But I also think it's important to recognize that even if we've optimized the clinical components, at least 80% of the modifiable contributors to health outcomes are associated with context and social determinants, and oftentimes things that of late I've been calling large-scale events. And I would say the most sort of pronounced in the last few years has been the COVID-19 pandemic, which has really transformed health in many ways. And I'm not going to talk too much about COVID, and that's intentional because I think we've talked a lot about COVID. But what I am going to talk about is that it's not just COVID. There have been many other things that I would consider large-scale events that are shaping the current healthcare context. And so I'm just going to pick a few from the slide that I think stand out for me. A lot of my work is with the Latino community. And so if we think about our southern border and the unprecedented migration from North America, from Central America, from other parts of the world through our southern border, individuals, families seeking a better life, seeking safety, seeking the chance to improve their economic and social circumstances. If we think about what's happened in terms of mental health and behavioral health in our country, particularly as it relates to polysubstance use, and what we're seeing as a country right now, sort of historic levels of anxiety, depression. We have an opioid crisis that has origins that are historical, but now they have been certainly sort of amplified and exacerbated in sort of our national response and how we think about the fact that across our country, many individuals are using substances that are laced with an opioid or directly using opioids, and that has resulted in a high overdose death. When we think about sexual and reproductive rights, what's happening right now around abortion, contraception, and other issues regarding SRH, my own work in the HIV epidemic, we've made unprecedented progress in sort of eliminating HIV in our country, and yet we still have roughly the same number of new infections in our country for the past decade or so, roughly the same number. I want to focus in on two more things that I think are really important, but all of these things are exemplars of large-scale events. But it would be, I think, I would not feel comfortable going forward without mentioning these two things. The first is widening inequality and the economic impacts in our country. You know, I was just reading the other day in the New York Times an article about more and more American families opting to not seek out healthcare and making really difficult choices between whether or not they pick up that prescription, they go to that visit, because of problems with their income, and that the costs of living, inflation, and our salaries are not really adequately meeting the needs of individuals and their families. And so that means that these tough choices are playing out in ways that there may be delayed care or foregone care, even when somebody has a provider, but they just can't afford to pay for those services. And then I want to really focus on one more point, and I am intentionally bringing this up in this way because I think it tends to be one that gets skipped over quite a lot, and that is structural racism. And I think that one of the things that became really clear with the murder of George Floyd was the country had to sort of be much more honest about what had been an enduring historical issue that had been long before the murder of Mr. Floyd. But I think as a country, it is undeniable, and COVID reinforced this, that there are really deep racial and ethnic inequities in health, and that those inequities are largely driven by structural racism. And how do we deal with the complexity of all the large-scale events that you see here: widening inequality, structural racism, new infectious diseases, massive events like migration to our country, more behavioral health concerns? And how do we prepare a workforce, a nursing workforce, that can provide high-quality care within this context? This has been the question that has been at the center of the work that we're doing here at Duke. And I would say across nursing, that nursing is grappling with these questions. And it's an exciting time, and we should be really proud of what we're doing as a profession. I think there are three things to consider when we try to understand these large-scale events. One is that the large-scale events oftentimes will present new challenges, and they create new inequities. And so a good example is COVID-19. It was a new challenge. There were mortality differentials between vaccinated and unvaccinated individuals. And so that was something that was a new sort of health inequity that really came from this large-scale event. What's also true, and I've mentioned, is that oftentimes these large-scale events can expose chronic inequities. And so I really like this image, because COVID-19, it kind of shined a light on the fact that there had been racial, racism and structural racism in our country, and that we were, prior to COVID-19 and certainly prior to the murder of, Mr. Floyd, we had not been willing as a country to really grapple with this. But the disproportionate impact of COVID-19 on communities of color highlighted structural racism. It is very much true that Native Americans, Latinos, African Americans were differentially impacted by diagnoses, hospitalizations, and deaths in regards to COVID-19. What often doesn't get spoken about are what I call synergistic effects, which is that third relationship. So some things that we were doing better or we were managing, they actually came together with new large-scale events, or perhaps two existing large-scale events interacted in such a way that it worsened. And this is something that I think we're not paying enough attention to. And a good example is what you see on the slide. And so, prior to COVID, I'll just use my own state as an example. North Carolina has had and continues to have an overdose epidemic, like many places in the country. We were doing better prior to COVID, but when COVID entered our communities in 2019, we saw this synergistic effect where not only were we grappling with the new challenges of COVID, but we were seeing that there was a worsening of what we had been doing prior to COVID, and we were actually making progress. And so we have record increases in overdose deaths subsequent to COVID. And so during the pandemic, we saw that there was a retreat from many people being able to access their sort of routine primary care, the management of their chronic conditions, many things that would have continued to progress and allowed us as a country to improve the population health of all. We saw that there's been some setbacks, and the setbacks are not simply best characterized as us sort of a waning, but they're synergistic because we see that the numbers are worse than they had been prior. And so this really speaks to how these things have come together in ways that have exacerbated an existing inequity. It's not just about the kinds of examples that I've given around excessive morbidity and premature mortality, but when we think about the health inequities, there are sort of additional externalities that impact other parts of our society. There are human costs that are worth mentioning. Again, given that we are nurses, we care about these aspects of the human costs. So I've talked a lot about excessive morbidity and premature mortality, unfulfilled human potential. This is really what we would contribute as individuals to our society if our life had not been prematurely ended, if we had not had more reliance on health systems and public entitlements because of chronic health conditions, what we would have contributed in terms of our optimal selves in the world. Eroded social cohesion, thinking through in times when we are feeling like our basic needs, health and social welfare needs, are simply not being addressed, then the fabric of our society, what brings us together, we know that we see erosion, we see more tension, more conflict, more opposition and difference. We also know that there's excessive bereavement that we could prevent, and I've talked a little bit about that as well. What is less talked about is the unpaid caregiver reliance. More and more as our country has more individuals with chronic conditions who will require additional assistance, our health system is more and more relying on unpaid caregivers, families, however that's defined, people who are significant others in our lives who are caring for us and who are not being paid. And all that has an impact on society that should be considered and that we should be concerned about. For those of us that care about the financial aspects of what I'm saying, I want to share what you see here, which is really, in my view, quite pronounced. The school here at Duke, we recently had Deloitte, the accounting firm, visit with us, and they gave this fantastic talk that was based on a paper. And their talk was called The Financial Cost of Health Inequities. And you can see on the bottom of the slide the citation to a paper that they published, which I would encourage everyone to actually read. And if there's interest, we actually have a QR code that I can send to Dr. Yearwood if there's interest, of the Deloitte lecture where they're talking about their calculations and what I'm about to share with you. We recorded their talk and it was fantastic. And so what is being projected on the slide now is that the cost of inequities today, it costs us $320 billion today. And this is not the cost of healthcare. This is the cost of the inequitable care, the ongoing maintenance of the inequities that we see. the negative sort of outcomes that are associated with systematic ways in which large segments of our society have chronic conditions, that have premature mortality, that have poor distribution of resources, and inadequate social circumstances. And right now, as a country, we're spending $320 billion. What's nice in the Deloitte paper is they actually make it very personal. And they ask us, when you think about this $320 billion, what does that mean to you as an individual? And based on the Deloitte calculations, the annual direct cost to individuals is $1,000. We each pay each year $1,000 of our taxable income to maintain negative health inequities. That was simply striking to me. And I would encourage folks to look at this paper and listen to that lecture to really understand how Deloitte went about calculating these figures. What's even more distressing is that they projected the cost of the inequities into 2040. And you can see here that those costs are estimated to be $1 trillion. And the annual direct cost to individuals for each individual in 2040 is $3,000. We will contribute in 2040, if left unchanged, individually $3,000 to maintaining negative health outcomes, inequities. And so again, this simply does not seem like a sustainable model in my view. And it seems like we need to think about a paradigm shift. What's further troublesome is that in that Deloitte paper, they make a point to say that many of the inequities are clustered among communities of color because of the poor distribution of resources and the social conditions in which many communities of color are sort of embedded, where we find ourselves living, working, growing up, et cetera. And so because of the increasing diversity of the US population, and because of some of the inadequate mitigation of the negative social determinants of health on communities of color and more broadly in society as a whole, there will be increasing costs in terms of health inequities, because more and more the proportion of who we are as a country will be characterized by being persons of color. And you can see that on the slide at the wide base on the right of persons of color is because in many communities, I'll just use Latino as an example, about 50% of Latinos are 30 years of age and under. So as time passes, that wider base will increasingly move up and will age. And as that sort of cohort is moving forward, given the social conditions, the distribution of resources, and also the harmful determinants of health, those things will shape the likelihood of chronic condition or premature mortality. And so what Deloitte is arguing is that our underlying population dynamics are also going to inform what the financial costs look like for us as a country. In my view, for a long time, this is not a new idea. And so I hope that you guys will appreciate that. My putting this slide here is not in any way suggesting that this is something that we've not known for some time. But I want to reiterate again that we must take action as a country. We need a paradigm shift. We need to better align healthcare and our system of healthcare with the needs of people in our country. Right now, we have what some have called the sick care model, that really the reimbursement is based on procedures and it's not based on reimbursing for health. We don't have a model right now that prioritizes prevention, that prioritizes health promotion, and that prioritizes restorative care, irrespective of where you are on the continuum, that our goal is to optimize your health. And in my view, what I hope that my colleagues at Georgetown University School of Nursing will also agree with me on is that nurses, because of our sheer size, that we are at the center of this, and that if we want to see a paradigm shift in our country, that because of our important role that we play in delivering care, not only in our country, but across the globe, that we are the workforce that can actually push the country to better align what healthcare is to what people need. And, it's often the case that I hear folks talking about us being the largest, more than 4 million registered nurses in the country. I often hear folks talking about how for 20 consecutive years, we've been the most trusted. What I very rarely hear being communicated, and I hope this will resonate with the audience, is that not only are we the largest and the most trusted, but we are highly skilled. And because of our skills and because of our competencies, that we are at the center of healthcare transformation. We can do this. And I think that nursing is leading the way. And I'm going to share some important thoughts that what we've been thinking here at Duke, and really invite us all to have a conversation about what you guys think and how we all can collectively come together to advance health in our country. So when I arrived at this school 2 years ago, we started a project, and the project that we started was really trying to understand, what have we learned about social determinants of health? What does the literature say about SDOH? And what was surprising to me is that, in 1961, that was the first time that we found an article that really spoke to social determinants. And it was published in the American Journal of Public Health. And you can see that for many, many years, there was reference to SDOH, but it was pretty sort of under the radar. So you can see that there was a long period, there's a plateau, until about 2010, when we started to see in the literature that there was this increase of papers that were being published on social determinants of health. You can see that from 2010 to now, 2023, that there has been really a proliferation of articles that have been talking about social determinants, and that's a good thing. I think what is also striking is that in this period, roughly 19,000 papers have been published on social determinants of health. And so what I'm going to do is I'm going to share with you what we here at the school did, because we reviewed all of those papers to really distill what have we learned and what can we say about ways to effectively mitigate SDOH. And so rather than have folks go out and read the 20,000 papers, we've done that, and we've actually written a number of papers that are in the process of being published. Two of them have been accepted and are now going to be released, and we're really excited about that. So let me tell you what we learned. So the first thing we learned is that nursing has been part of this. This is not new to nursing. Nurses have been indispensable leaders in the past. We should take great credit for that. We have been focused on SDOH, the present and also the future. And there are a couple of great exemplars that are here. By no means are these all of the examples, but they do provide some powerful sort of instances where nursing has been leading. So one has been the fantastic new strategic plan for the National Institute of Nursing Research, NINR. I happen to be a strong supporter of the new strategic plan. I realize that the nursing profession has had some, I would say, some difference of opinion in terms of some of our traditional areas of nursing science. I want to say that I view many of those things as being totally possible within the context of the new plan. And what I like about the new plan is that it really prioritizes the most pressing health and societal challenges that we face, and puts front and center the social determinants of health. The Council for the Advancement of Nursing Science, fantastic conference last year on social and structural determinants of health. The Future of Nursing report, the most commonly downloaded report of any of the reports of the National Academies, the 2030 report, and prior to that, the prior Future of Nursing report. Centered in both reports are social determinants of health. And also more recently, some of the schools under leadership of Emory and other institutions put together this special issue in the American Journal of Public Health that really highlights the important role of nurses in addressing social determinants. All of this is good, and it would be completely inaccurate of me to not recognize all the ways that nurses have been contributing to advancing health through effectively addressing social determinants. I think the second thing that I want to convey from the review of the 19,000 manuscripts is that there has been an evolution. And the evolution is depicted in its simplest form on this slide. And so the first thing, in the 1961 phase going forward, there was recognition that social determinants were shaping health outcomes. And at the time, that was the language that was being used, health outcome. And that was pretty pretty profound at the time, because up until that point, much of the focus, and actually for a long time afterwards, and some would argue even today, it was really an individual focus, that there was a lot of attention to individual behavior that was sort of driving health outcomes. And I think what we started to see in the first sort of phase of writing about SDOH was that context really does matter. What was also true is that the mechanisms by which the context shapes the outcome were largely not really understood. We didn't fully recognize, well, what exactly is it that happens? And how do we go from sort of economic disadvantage to, greater sort of incidence of negative health outcomes? And what is that sort of presumed causal link? And it was sort of a big question mark. There was an evolution, fast forwarding in the literature, and we still have social determinants being recognized. But now two things emerge. First, we went from a health outcome to a health disparity. And that was interesting to me when we started to, as a group, try to understand, well, what do they mean exactly by a health disparity? And this was really recognition of the underlying systematic differences in health outcomes that were clustered in certain individuals or communities or populations. And this recognition that there were systematic health disparities led to this notion of the health disparity. And so these outcomes clustered, and therefore they became a disparity. What was also really interesting is that at this time, there was this tendency to start introducing this concept of vulnerable individuals, vulnerable families, vulnerable communities. And vulnerability became the sort of language that was used to explain health disparities. And so often there was literature that was being written that in its simplest form would say there's a social determinant that renders a community or an individual or a population vulnerable, which in turn leads to a health disparity. And it wasn't exactly clear, well, what exactly makes one vulnerable? What makes a community vulnerable? And how is it that we can do something about vulnerability? The perspective was more what I would call deficiency focused, and it had a lens that was about vulnerability. And I'm going to be honest, I participated as a student, and to be really honest, early in my career, I've been a professor for about 20 years. I taught courses that were entitled Working with Vulnerable Populations. And at the time, I thought that that language was entirely appropriate, that it was symbolizing my commitment to somehow addressing their vulnerability. But what I never really asked myself, well, how is it exactly that somebody becomes vulnerable? What then happened was there was an evolution again in the literature, and what really dominated the next generation of papers was still the idea of social determinants mattering, but now there was this reference from disparity to inequity. And there was this health inequity that was really getting at the idea that there were injustices, things that were unfair. There were social processes, things like racism, that were shaping these clustered negative outcomes that prior to the use of the term inequity had been called health disparities, and that now were being called inequities because there was a piece that was unfair and unjust, and there was recognition that there were social processes that were also operating. What lingered was this notion of vulnerability, and their vulnerability is on the slide. There was a determinant that made an individual, a family, a community vulnerable, which in turn led to a health inequity. So this is kind of where we are. The current dominant approach is that we've got a social determinant of health lens that we do recognize that social determinants do matter, both in terms of being protective, and good social determinants advance health and well-being, but also harmful social determinants sort of advancing health inequities. There's an element of what scholars are writing about that does speak to systematic differences in negative outcomes that move beyond a disparity because they are unjust, unfair, and that are best characterized by the term health inequity. But there's still this lingering sense of vulnerability. And what exactly is vulnerability? And so what was really interesting to me is that despite our current model primarily being what's depicted on the top of the slide, there were some really interesting scholars that were writing about some other things. One of the scholars is Thomas LeVeist, who's down in Louisiana, who is the dean of the School of Public Health at Tulane. And he's been writing about vulnerability, and he has challenged the term vulnerability and said we should get rid of that. How exactly is one vulnerable? And he argues, and others have argued, that you are not vulnerable, you are exposed or susceptible. And that exposure and susceptibility are two dimensions that we can do something about. We can actually reduce your susceptibility, and we can actually reduce your exposure. And so in that literature, there is a real call to action to move away from vulnerability and start to think about the mechanisms as being exposure and susceptibility. There has been a greater attention to social processes. I think probably the most important and pronounced being racism and structural racism. And how can we actually develop a science of effective mitigation of racism in terms of health inequities? And there's also been greater attention to resilience. And I want to be really clear that I do not mean this sort of kind of resilience that has historically been tied to the origins of our country. You know, as the United States, we value, it's sort of in our historical roots, this idea of sort of picking yourself up from your own bootstraps and sort of going the rugged individualistic perspective that somehow the cream rises to the top and overcomes. And that's not what's being written about. What's being written about is the idea of a strengths-based resilience. Are there aspects of communities that have experienced health inequities that represent a kind of strategy that is multi-level, both at the individual, the institutional, and the broader societal level, that are lessons that we could learn that would help us to understand how is it that despite adversity, communities thrive? And if we could understand the science of those more proximal strategies that are at the individual level, the sort of institutional level, and broader society, could we bolster resilience and actually think about that as being part of our interventions? So all of those articles, the 19,000, they really identify 8 principles, and the 8 principles are here on the slide. And so this is sort of like the Cliff Notes version. If you didn't read the textbook, this would be the Cliff Notes version of what's in those papers. And I'm going to review each of these 8 because I think they're very important. And then where I'm going to go is I'm going to show how we have integrated the 8 principles into one unified framework that really allows us to apply the concepts to more effective mitigation of harmful social determinants. So the first principle you can see here is that there are underlying causes of health inequities. And you can see what's really beautiful is on the left, the tree and the roots. Often what we see is the tree, and a lot of our interventions tend to focus on the tree, and that's important. But what is not being fully understood always are the roots that are underneath and those fundamental causes. And one of the principles that was in the literature, there are these underlying factors that can be distal, they can be exposures that really influence risk or protection. And that these distal factors, they are sort of core causes of inequities that we see in society. Another important concept is that context matters and that context shapes health inequities. This is another one of my favorite slides, the sort of sharks in the pool. And in a second, I'll show you, a really great example about community A, community B. But there is an environment of protection and risk, and that protection and risk is not exogenous to the individual. It's actually endogenous, outside of the individual. And so it's not, I did have the opposite way. It's not exogenous, it is exogenous to the individual. It's not endogenous to the individual, But what's important here is that there are 4 dimensions of the risk environment. So there's the physical environment, the social, the economic, and the policy. And you can see in this next slide, really a great example. And so in this slide, let's imagine that we have 2 populations. And one population has a disposition in life that they live in community A, and another population has a disposition in life that they live in community B. And in both instances, the individuals who live in those communities must swim through these two pools. And so if you live in community A, you swim in community A pool. If you live in community B, you swim in community B pool. And what's striking about this is that in both instances, it's the very same behavior that's occurring. And yet the outcome is going to be very different. And the reason for that is I certainly would want to swim in community A. There are fewer sharks in community A. Community B has many more sharks, much more likelihood of being bitten by a shark. And then let's imagine, just to make the case a little bit more complex, that in community A, where shark bites are infrequent, there is a great nurse, there's a health institution. There are services that when a shark does bite an individual, which is something that is infrequent, there's a response, and that response is fairly rapid, it's quality services, and it really seeks to effectively mitigate the shark bite. Community B, there are many more sharks, so as someone is swimming, the likelihood of being bitten, and in fact, the number of bites in community B is greater, and when someone does get bitten, they linger in the pool more. There's less of a response, fewer resources, less adequate ability to effectively mitigate the sharks. In my view, there's sort of three components that are operating. There's, of course, the individual's behavior. One option is don't swim in community A or community B. But for most of us, we exist in a context where we are, in fact, going to swim in one of the two pools. And really what drives where we swim is our disposition. And so the second part is the recognition that the prevalence of the sharks is going to determine the health outcome in part. And then the third part of it is the response and how we respond. And I think those three things are important to understanding how we can effectively mitigate it. And this third principle is sort of getting at that. It says that contextual disadvantage is not deterministic. And so just because you start from a certain place in life, a community of disadvantage, it doesn't mean that the outcome is always going to be a particular negative outcome. There are opportunities at different levels that we can reinforce or weaken. And that example of the pools is, and the sharks is what I was getting at in terms of the multiple places that we can intervene. This sort of captures it in this example in both community A and community B, or swimmer A and swimmer B. The prevalence of sharks is the same, but one community has a nurse, has a lifeguard, has medical health care. And then also you see there's a difference in terms of individual behavior. And so the outcome is different with swimmer B getting bitten. And you can see that even though both communities have the similar prevalence of sharks, we can get a different outcome. A long way of saying that there are multiple places where we can intervene in terms of social determinants. There's also recognition, and this is another important principle, principle 4, that our advantage or our disadvantage is cumulative over life, and that as we experience shark bites or whatever it may be, the harmful social determinants, that our early life exposures, they actually accumulate. If they are negative and there's risk, that risk accumulates over the course of our lives. And if we have positive sort of exposures, then the benefits and the advantage that we have, it accumulates over the course of our lives. And so it's important to think of things from a life course perspective. This is fascinating. I did not hear about this in my nursing education. I wish that I would have heard about it. It's something that as an adult I've studied and that I've been studying more of. And so this is biological embedding, which is a very, very important concept that I wish more schools of nursing included in their curriculum. And so biological embedding is the idea that the social is in fact the biological. And what it really says here is that there are social conditions that actually alter biological processes, not only in the short term, but they shape things in the long term. These alterations in biological processes are stable, and they can have really dramatic effects in terms of long-term health and well-being. And so you can see here that over the course of life, that these sort of social conditions that they initiate and they sustain, and they can impact our health in the long term. And so very, very important concept and something that we need to understand more. There's also this principle of the family as being a particularly important context. You can see here that these SDOH benefits or harms operate intergenerationally, both from parent to child or within one family at one point in time, but that family may be multi-generational or across generations. And so again, we see that it's not just individual, but there's a family component to how SDOH is operating. And then there's also this principle, number 7, of this syndemic-like quality of SDOH, particularly harmful SDOH, that they cluster, they interact, and they wind up reinforcing one another. And so you can see here a good example is that you may have a biological mechanism with a socio-contextual mechanism. And so a biological mechanism would be, for example, the relationship between HIV and a non-HIV STI, and how that increases the likelihood of acquisition of HIV or transmission of HIV. And then a socio-contextual synergism where you can have same exact example, but in this case, HIV acquisition or transmission is exacerbated by substance use. And so again, where we see the clustering of these health inequities in similar individuals or populations. And then the last principle is really this idea of social injustice and structural racism as shaping SDOH. And so in this case, your positionality, our positionality, each of us has a particular social positioning, and it's based on our intersectional identities, and that identity and that positioning exposes you to certain social processes. And some of those social processes are unjust, they're unfair, and they fuel health inequities. So taking all that together, these are the principles that are depicted here, both the principles that were in the literature, as well as the concepts that I mentioned earlier that were mentioned, but were not as pronounced, like resilience and susceptibility and exposure. And each of these figures represents an important concept or principle in the actual literature. Think what, in the interest of time, I'm going to skip over is this slide, but I will send these slides to Dr. Yearwood. And I think that one of the things that is important is there's a very brief animated video, it's about 8 minutes or so, that goes through and integrates all of the principles into one framework. And once you listen to that, it's a really clear articulation of how these have been brought together in a dynamic model. And the dynamic model is presented here, which is the framework that we are very proud of that we've developed here at the School of Nursing at Duke University. And I think one of the things that I want to say that there are many frameworks for social determinants. You know, one of the ones that I like, actually two of the ones that I like a lot, there's one by NIMHD, the National Institute of Minority Health Disparities, and also the WHO has, there are 2 frameworks that I like a lot. But what I would say is that there are different kinds of frameworks. And this by no means is a criticism, it's simply an observation. There are some frameworks that are more static and that identify domains. And if you look, for example, at the NIMHD framework, that is what I would call a domain-specific framework, where there are multiple domains, multiple levels, and it helps you to characterize and think through all the different ways that social determinants might be contributing to a health inequity. Same with the WHO framework. What's really different about the presentation that I'm sharing today is that our framework is a dynamic framework. It looks at processes and it moves beyond simply characterizing domains and assessing what could be shaping a health inequity. It has different domains in it, but it also makes very specific statements about relational forms and about the importance of thinking about how these domains are related to one another. I would encourage you to check out that video in the slides. And I think it will talk about the dynamic aspects and it will build the model and walk you through an application. At the School of Nursing, we have been using our framework to develop what we call nurse-led interventions. We are brainstorming what we're calling a nurse-led model of care, which are the conceptual principles that really are synonymous with nursing practice. And through our nurse-led interventions, we are bringing the model to life in ways that draw on the principles that we've talked about in the presentation today. There are many examples here, just a few. Very proud of the faculty. They're doing a fantastic job. You can see Dr. Brady Granger is working on hypertension heroes and looking at health inequities in terms of Black women in Durham. You can see Dr. Deborah Brandon and colleagues are looking at preterm infants in the NIC ICU and thinking about ways to better engage parents and how the parental engagement can improve sort of outcomes in the NIC ICU. Dr. Doherty, Sharon Doherty, is looking at chronic diseases in adolescents, and Picasso is an example of ways that we can use a nurse-led intervention that draws on principles from our SDOH framework to help young people living with a chronic disease. I'll point out two more. One is Dr. Shanita Randolph doing terrific HIV prevention work in rural North Carolina in, salons and really helping African-American women in beauty salons access pre-exposure prophylaxis, and again, bringing this kind of framework. And then Dr. Rosa Gonzalez Guardia, wow, her Ser Hispano study is really looking at early indicators, early markers of changes at the biological level that really map onto this notion of biological embedding and how those indicators correlate with social behavioral reports and the meaning of those early changes on longer-term chronic disease. I won't go through all of these. I'll simply say that we are trying to put into action what we see as being an effective way to mitigate harmful SDOH into applied projects across our areas so that we can demonstrate the value of nurses and what we bring to helping to shift the paradigm in healthcare. In the interest of time, I'm going to let you guys read this slide on your own. I will send the slides to Dr. Yearwood, make sure that you guys all have it, but it really looks at the status quo and what is the new component. And you can see in the parentheses that the status quo is what's in the parentheses versus exclusively whatever it is, or and then the part that is above that is sort of the new perspective that we are arguing in our framework. I want to end before we get to Q&A with saying that we have created a website that is called Doosan Trailblazer. And what's really cool about this is that we are asking for help. And I mean that in a very sincere way. We as a school have decided that we are taking really bold steps. Our North Star is ending health inequities, and we are moving away from solely relying on internal indicators of how successful our school is. And we are starting to think about, if we evaluated ourselves, how is it exactly that we're contributing to ending health inequities? And we need help because we will not be able to do that alone. We need every single school of nursing, all nurses, all healthcare professionals to think about how we can shift that paradigm from the sick care model to health promotion, prevention, and restorative care. In support of that, we've developed a couple of resources that are free, that are downloadable, that are available to anyone, and we encourage folks to access them. We have an interactive digital guide that builds the principles in that animated video that I did not show today, but is available on the site. We have a lecture that's actually better than the one that I've given today because it's a little bit more clear. And I did a couple of takes when I did it. It was done in a studio, so it was pretty structured, but it's a great lecture that can be used in courses and that can be easily shared. There's a downloadable set of PowerPoints that has a lot of information that can be easily integrated into classroom instruction or shared as part of presentations. And there's an interactive quiz that interacts with social media that can be shared with others. And you can ask folks to test their SDOH knowledge. And we are working on another part of our Trailblazer site, which is something that I'm learning about, which is called augmented virtual reality, where we're going to have an interactive experience in the coming months that will walk nurses and other healthcare providers or anyone through understanding how to effectively mitigate using the principles that have been laid out in my presentation. With that, I'm going to stop and I'm going to say thank you so much for your attention. I hope that was interesting. Dr. Yearwood, I'm going to pass it back to you.
Well, what can I say? You knocked it out of the ballpark. Thank you, thank you, thank you so much. And I'm sure I'm speaking for everyone who is here listening to you. You have given us so much to think about. And it is incredibly generous of you to open up all your resources. This is going to be a partnership between Duke and Georgetown. Okay, we're right there with you. But thank you for everything. And Dr. Guilamo-Ramos, one of the little known factoids is Dr. Gonzalez Guarda is a graduate of Georgetown.
I
So
know.
she's one of our alums, okay?
Yes. She loves you guys. She often talks to me about the wonderful time that she had in DC and how much she grew. And that prior to being in DC, she had been in Miami. That had been her community of origin. And that DC really represented a big opportunity for her to spread her wings. And Georgetown School of Nursing gave her that opportunity.
Great, thank you. We have some questions in the chat, and let me go with, I'm going to go with them in order. One of our participants, one of the folks who is joining us asked the question, do you think the lack of representation of nurses from underserved communities contributes to some of the inequities that you're talking about?
Absolutely. So I think our workforce, what a great question. I'm really happy that's come up. So we have to do a better job in nursing and in all health professions to really recruit a workforce that is diverse and inclusive. And the reason for that is that the perspectives that we bring, our lived experiences, our positionality, how we go about aligning care with the needs of communities that we have intimate knowledge of, because oftentimes we come from those communities. That has value. We know that diverse, inclusive teams produce better outcomes, and we know that there are aspects of what diverse nurses can bring to care that can be taught. We can teach that, but too often, if I'm really being honest, we haven't done a good enough job at being able to teach individuals how to actually incorporate those aspects. And so if you look at a lot of what dominates our knowledge and sort of the kinds of things that we learn, they tend to be heavily influenced by majority group perspective. And I think it's important that we have diverse colleagues who can start to bring more of the kind of things that are indigenous to our communities into the formal lexicon of what we teach, what our curriculum looks like, and how we deliver care.
Great. Thank you so much. And we have Dr. Peggy Chin, who joined us for this presentation. And Dr. Chin's question is, I have been questioning the terminology social determinants of health, because in reality, we seem to be talking more about social determinants of illness or sickness and death. Would appreciate your thoughts on this.
So Dr. Chin, what a great question. So I think that I'm very intentional when I talk about the harmful social determinants of health. That's what I'm trying to mitigate. But I actually think it's two sides of the coin. You're absolutely right. There's no reason why social determinants of health can't be protective and positive. And part of what I was hoping to convey was this idea of accumulating benefits, advantage over the life course, that if you have the right social determinants capital, if you have social processes that facilitate your belonging, your inclusion, your embrace as a diverse individual, if you have limited exposures, you have reduced susceptibility, you, over time, you are accumulating a lot of advantage. And those social determinants of health are shaping positive outcomes and not the inequity. And so I think the opposite of what I've been saying is also true. Both of those things are operating. I think the thing that I've been troubled by, and the reason why I've been focusing on harmful SDOH, is because of the profile of the country that I started. More than half have a chronic disease, the reductions in sort of mortality. And what I failed to mention is when I look at the differences, for example, in the average life expectancy by geography, when you zoom in, what you see are profound racial ethnic differences. Life expectancy for an African American in Baltimore or in Los Angeles is very different than life expectancy for a white individual in Los Angeles or in Baltimore. And so not disagreeing, Dr. Chin, simply saying that we've got to work on both sides of that coin.
Great, thank you. Lots and lots of kudos to you. Dean Waite says dynamic presentation, and we look forward to working with you.
I do. Wait, I'm going to be at ACN. I hope that I can grab you for a cup of coffee if you happen to be there. I think it's this weekend, Saturday, Sunday. So I will be there, and I'll make it a point to look for you.
And several kudos to you on this presentation. Let's see, Dr. Chin followed up with, and susceptible groups also have strengths that we might need to focus on more. I think your comment about resilience was really a key piece. I think often those of us who do assessments are sort of not paying attention to the strengths that folks that we're working with bring to the table. So I think that's really helpful.
Dr. Chin, just to clarify, again, the same point is absolutely correct. And I love what Dr. Yearwood just shared. Susceptibility is a biological concept, and it does tend to be applied in terms of sort of what your risk is. But there's also a protective component. So, for example, in North Carolina, this was pretty shocking to me. I don't know why it was, but it was. And it wasn't just North Carolina. But I thought after COVID that we had learned some lessons about distribution of vaccines and how that was important in terms of allocation of resources. And when Mpox hit the United States, we saw in North Carolina there was an outbreak among Black MSM in the state. And yet 7 out of 10 vaccines for Mpox were given to non-Black, non-male individuals in North Carolina. And so where there was reductions in susceptibility was in the non-Black male or non-Black male population. And so where there was increased susceptibility was because of the lack of Mpox vaccine being delivered to the community that was at greatest risk. There was more susceptibility to acquisition of Mpox. And so what the mistake is that when the Department of Health started to report about Mpox cases among Black MSM, over time, what gets dropped is the understanding that what drove that disparity, or that inequity, I should say, was the lack of vaccines to that community. And it was not there being male or Black or MSM. What was driving that inequity was that the vaccine wasn't getting to those communities, and therefore they did not have biological protection. They had increased susceptibility because of the lack of the vaccine. So hopefully that is explaining kind of the other side of the coin, that there is a protective aspect as well, and it's definitely related.
Great, thank you. And I have a question here from a long-time colleague and someone who's presented here for us at Georgetown, Dr. Vicki Hines-Martin from University of Louisville. Vicki asks, to what degree does your framework guide nurses in addressing the current political and structural challenges towards equity?
Wow, that's such an interesting question. And so I almost would like to ask Dr. Yearwood if Vicki would like to maybe clarify the question a little bit more, because, I just presented this topic in St. Louis, and I'll just use St. Louis as an example. I had a lot of meaningful discussion in St. Louis, and what I learned being there was that there's something called the Del Mar Divide, the northern part of the city, tremendous inequities that are unbelievable to characterize, that have origins in the history of St. Louis, and then really the southern part of the city, much more affluence. And what was interesting to me, Vicki, was talking with our colleagues at the University of St. Louis School of Nursing, really understanding that there are different sentiments in our country around even the term social determinants of health, or health inequity, or structural racism. And I could probably list other words as well that in my mind make perfect sense to use and reflect the science of what we understand about the current health status of our country, but needing to be particularly aware that everyone doesn't feel the same in our profession, and certainly not in our country, and that there needs to be sort of a re-examination and commitment to allowing science to guide sort of how we frame things. And so I don't know, Vicki, where you were going with that question, but I think the framework is a great way to focus interventions on nursing science. I was asked recently what I thought was provocative question when I was speaking about the model. And it was a very focused question. And it was about reparations for African Americans. That was the question. What did I believe about reparations for African Americans? And I paused for a second and I thought about, well, what is really being asked here? And, is it really as simple as my saying what I believe, yes or no, or maybe? Or is it that there was some other potential reason why I was being asked that question? Highly charged issue, one that potentially could have fragmented the conversation in the group, and it could have become an argument for difference and not really advancing what we care about, which is advancing health equity. How I answered was to pull the model up. And I said, well, let's look at the model and let's walk backwards. And one of the components of the model is social determinants of health capital, which has to do with the allocation of housing and income and education and health. And there are processes. But if we look at the model and all the components, one of the important components is capital and is income. And so that was my way of providing the audience with my thoughts on the importance of thinking through ways that we can address historical sort of inequities in income, and then the important role of reparations or some mechanism for being able to do that.
Great, thank you. I think Dr. Hines-Martin has a sort of a second part to this. She says, I find that nursing theory is lacking the SDOH perspective overall. Should we be examining those for change or as barriers to this SDOH perspective? So basically going back to our nursing theories.
Dr. Hines-Martin, thank you. Forgive me for calling you Vicky. I didn't quite get their last name. So Dr. Hines-Martin, thank you for the question. I would say absolutely. And I hope that nursing broadly will embrace this. I'll be honest, I love my school. I'm a graduate of the school. I studied here and I'm now the dean. Great faculty, but even in our own school, we've had challenges being able to meaningfully address social determinants of health. I think it's one thing to think about case studies or simulation where perhaps, and I'm not saying that this is the only way that it's done, but perhaps the case becomes about a Latino family, or perhaps the mannequin that we use in the simulation lab is now potentially brown and could be a Latino family. Well, that is certainly a step closer to modeling what an inclusive patient experience might look like, but it doesn't get at the heart of what we need to truly understand to address the health inequities. I would ask us all to push further. The theories that were developed at the time that they were developed, what really got highlighted as being nursing theory tended to reflect the dominant views of society at the time. And we all know, and a great reference for this is actually the commission report from the American Nurse Association on racism in nursing. We know there are historical figures that we never learned about, we never heard of. They simply didn't exist, and yet their contributions were amazing, and they shape nursing today. And yet too few of us actually know about that work. Recently, I was being asked about my model. I was publishing, the paper, one of the papers in a journal. And one of the comments I got back from a reviewer, well-intentioned, fantastic reviewer, was that we should take out the reference to the Center for Latino Adolescent and Family Health. The model is entitled the Duke University School of Nursing Center for Latino Adolescent and Family Health. And the rationale was that viewers might, or readers of the manuscript might see it as being Latino specific. And that if I wanted it to have more generalizability to non-Latino communities, that I should consider removing the Latino reference from the title. I wrote back to the editor and to the reviewers, and I respectfully disagreed. And I said that I think it's important that contributions that come from all nurse scientists, irrespective of their race, ethnicity, or whoever they may be, including Latino scholars, that our contributions are not solely for Latino populations, but they could have utility for society more broadly. And so I actually would like to keep the title with Latino in it, not because it only is for Latino, because it comes from a group of Latino scholars that are trying to advance health for the country.
Great. Great. I want to, and I think I had mentioned this to you when I heard you talk in September or October. Two of the theorists that I think we can all in nursing, and I'm going to probably get some darts thrown my way when I bring back Martha Rogers, because I'm an NYU grad, and Martha Rogers, I think, was ahead of her time when she talked about some of these issues that we're talking about today. And then, part of the model that you're sharing with us is very, very steeped in Bronfenbrenner also. And I think that for those of us who teach students, one way to sort of revisit, we can revisit those theoretical perspectives as a way to also appreciate them, but also understand how they're relevant today. I mean, those two theorists are very relevant today.
I think, Dr. Yearwood, just to be 100% transparent, so prior to being a nurse, I started my career as a social worker and spent many years as a social worker. And just as an example, Bronfenbrenner and that whole ecological systems approach has very much shaped my thinking. And there's no way that isn't reflected in the framework that I and others in my group have presented. We stand on the shoulders of others and we try to incrementally improve. I think our contribution is to move from a static domain model to really how do we think in a dynamic way with processes and interventions, and what do we do about the inequity? Because to be honest, and I hope that nobody will be upset or in any way offended by my saying this, I think we are a little saturated of simply observing or describing inequities. We have to do something. And I sincerely believe that nursing is at the center of that. We can make this change.
And I think part of what the health equity perspective is if we're not engaged in action, we're not doing anything. We're actually probably reinforcing the bad stuff. So thank you for reminding us about that. I'm seeing quite a few other questions, and I want to get to some of these, and I'm trying to take them in order. Monica, your question is your statement and then a question. Thank you for your thought-provoking and comprehensive presentation. I especially appreciated your attention to vulnerability. Admittedly, I struggle with the word vulnerability. I used to teach my students that we are all vulnerable in some way at points throughout our lives, as opposed to only low-resource communities or certain demographic groups. Can you talk more about how we can push this thought forward? Push this thought forward.
Well, Monica, thanks so much for your positive comments. I think for me, I never saw vulnerability as being necessarily a word that we shouldn't use. And, I admitted this during my talk that I used in my own courses. I went back to some of my course syllabi and I saw that I had vulnerable populations in the title. And some of my favorite courses as a college student and a graduate student were courses that dealt with specific populations that were sort of deemed or termed vulnerable. I think what I have now appreciated in the last 2 years is that the term vulnerability, it's kind of an opaque term. It doesn't really provide context in terms of, well, why exactly are populations vulnerable? And I think what I fear the most is that it doesn't move us to what I heard Dr. Yearwood saying just a second ago, action. What do we do given that a community, a population, individual is vulnerable? I think that some of the work that has come from Thomas Levice and colleagues around exposed and susceptible, I think his argument, and I actually appreciate this, is that if you're exposed, well, how can we actually mitigate that exposure? And if you're susceptible, then how can we shore up that susceptibility? And I like that because there are specific actions that we can take. And I guess part of what I was trying to also convey, Monica, in my example of MPOX, is that too often, because of the way that our country is set up, we segment on race and ethnicity. And so we start describing, let's use, for example, fantastic organization, institution in our society, the Centers for Disease Control and Prevention. So you look at their website, almost everything is segmented on race and ethnicity. So we wind up with narratives that actually start documenting differences by race and ethnicity, which over time, we then associate those inequities with those groups. And that becomes the dominant perspective. And we never take a step back to sort of think about, well, what's really underlining that? What's driving that? And those of us that would consider ourselves, and I certainly thought of myself this way, as being more on the progressive side, more of a lefty, I would say, well, those are vulnerable communities. Historically, I would have said that. Now I question and I say, well, how is it that this particular individual, family, community is exposed? How are they susceptible? What can we do about it? And with that racial ethnic segmentation that we see in the way that we characterize, would we see that if we intervened with exposure and susceptibility? And I would argue that more and more we would see that that goes away. It would certainly would be reduced. So I don't know if that's helpful, Monica, but I think we have to be very cognizant that the way that we characterize things, that we depict that narrative in our scholarship as nurses. And if we write about deficiency perspectives, if we simply observe and document inequities, then the narrative becomes about that. And, you know, another great example, if you look at the literature on MSM, most of it is dominated by HIV. And so you very rarely hear about MSM and other health issues or health or strengths because it's mostly about HIV. And so that's kind of the connection that people have made. And, you know, I really welcome across all of our areas, different perspectives, different views, more strengths, more resilience, more ability to look at not simply characterizing, but making what is opaque much more clear.
Great. Thank you. We have about 5 minutes left. So Dean Waite writes, you talk about biological embedding that occurs in children and adults. That's important in the curriculum. I similarly think about implications of epigenetics and harmful SDOH.
Yeah, so I think, Dean Waite, great question. So in my mind, biological embedding, it's the endocrine system, it's the brain and neurotransmitters, it's genetics, it's the microbiome, it's also the immune system. And I think that there are changes across each of those that we need to understand that are both in the short term and long term. And I hope what I'm trying to convey is that nursing and health more broadly, that we would benefit tremendously from more investments in understanding early pre-disease indicators of potential long-term predictors of chronic disease. And if we could intervene much earlier, could we change the model of care where prevention and where health promotion become more central? You know, as a nurse, I learned a lot about clinical indicators, but they were usually once someone developed the condition. And so, you know, I learned about an A1C or a certain sort of blood pressure reading or, you know, whatever it may be. And at that point, yes, there was discussion about health promotion and, you know, lifestyle and those kinds of issues. But I didn't really learn about things that I could see much earlier on, given the profile of a particular patient, that might have alerted me as a nurse to doing very specific kinds of interventions. And that's something that, you know, at Duke, we're thinking about, and we're trying to shift the paradigm further upstream. And what would care look like if we were intervening much earlier?
Great. So I'm going to violate my own rule that I was following the questions in order, because this one is from Dr. Kelly Anderson. And she says, thank you kindly for this wonderful presentation and the resources. We will be beginning our PhD in nursing program here at Georgetown in the fall with a focus on health equity and ethics. Can you share your thoughts on those two foci and how to develop nurse scientists to lead in these areas?
Wow, what a great question. So Dr. Anderson, I would love to talk with you. Dr. Yearwood has invited me at some point, I think with the blessing of Dean Waite, to the school. I look forward to visiting. Would love to sit down with you. We're redoing, Dr. Rosa Gonzalez Guardia has redone with the doctoral faculty here at Doosan our doctoral curriculum, much heavier emphasis on health equity and much more rigor being paid to well, what kinds of methods and questions and, research designs, analytic strategies, what is the substantive content that our students should be learning so that we can better train the future nursing science workforce to build on what has been excellent and also address some of these new areas that have been, to be rather honest, they've been sort of long-term historical challenges for us. And so, would welcome, Dr. Anderson, an opportunity to connect you with Rosa. If you guys don't know each other, would welcome an opportunity to talk with you guys when I visit the school, and we would be happy to show you kind of what we're working on and the direction that we're going.
Great, thank you. And I have a question. This may be the last one from Dr. Melody Wilkinson, who actually, I think, went to Duke also. Given your background in HIV, I have a question regarding the Ryan White program. When implemented to its fullest, it addresses social determinants of health and has demonstrated positive health outcomes. There seems to be tremendous application of that model more broadly. However, it is not replicated with other medical conditions. Do you have thoughts about why highly effective models that exist are not being replicated?
Oh, Dr. Wilkinson, what a great comment. So I think one of the products that we're working on that is on the list of things that we're doing here at the school is that we do have a handful of programs and specific interventions that have demonstrated that they have made significant impacts on reducing health inequities. And the Ryan White program within the HIV space is an example. It's far superior to any of the outcomes that we see outside of the Ryan White care context. And a large part of that is because it's so comprehensive and because it addresses so much of the needs that a person living with HIV has beyond just their medical care. All of those things that I showed at the beginning in terms of housing and food security and psychological and sort of behavioral supports, et cetera. Ryan White is built in a way that it provides people living with HIV that model. That's a model that one could argue that our country would benefit from if everybody had a kind of Ryan White program for their healthcare. It would mean that we would have to think differently about health in our country. And, as a follow-up to our conversation today, and I hope that this is not too provocative, I just read a paper in, I believe it was in the New England Journal of Medicine, but it could have been in JEM, I forget. It was in my morning email that I get the list, the emails that show new papers that are out. There was a paper that I received that was about greed in U.S. healthcare, and that greed is the number one reason why we have the health inequities that we have today. And there's some very specific things that the author, who happened to be a physician, was arguing that we should do to turn that around. I would say, Dr. Wilkinson, Ryan White's an amazing program. It has demonstrated great outcomes, and I think Americans and everyone in the country needs a healthcare system that's like Ryan White or better.
Great, thank you. Well, I think we have just been incredibly lucky to have spent some time with you. We have a few more questions in the Q&A box, and we'll save them and maybe send them to you, Dr. Guilamo-Ramos. And if you could just type a quick response, we'll get them to the folks who sent it. That would be really great. And we really appreciate you. And we look forward. I don't remember if the Academy is in October or November, but you've got an invite to Georgetown. And we would love to have you spend some more time with us. And of course, this goes both ways. So you can invite us down to Duke because we're very happy to work with you and join you in this journey. I think it's an amazingly wonderful thing that we're doing. That you're doing, you and your faculty, and we're absolutely applauding you and would love to be part of that.
Thank you so much, Dr. Yearwood. Thank you, Dean Waite. Look forward to collaboration and certainly count on us as well. We want to have strong partnerships, and we consider Georgetown School of Nursing one of those partnerships. Thank you very much for the invitation.
Thank you. Have a great day.
Take good care, everybody.